All right, well, we are at 8 a.m., so welcome everybody to Medical Grand Rounds. Today we have a wonderful talk by Priya Pophali in the Division of Hem/Onc and Palliative Care. And to do the formal introduction is Dr. Carrie Wazinski, our chair, our division chief of Hem/Onc. So, Carrie.
Good morning, everybody. It really gives me great pleasure today to introduce Dr. Priyanka Pophali. After receiving her medical degree from Indira Gandhi Government Medical School in India, she went on to complete internal medicine training at the Cleveland Clinic, followed by Hematology Oncology Fellowship at Mayo. In 2019, we were really excited to recruit her here to the University of Wisconsin, where her clinical practice focuses on the treatment of patients with aggressive lymphomas, cellular therapies, and she engages actively in clinical research for these patients. Early in her career, she already has multiple publications on cancer survivorship, including cardiac outcomes and the impact of diagnosis and therapy on a unique patient population, those that are adolescent or young adult survivors. In 2024, just recently, she was named the director of the UW-Carbone Cancer Center Survivorship Research Program, and we're really excited what she's going to do with that program. So I'm really looking forward to her talk today on cancer survivorship and lymphoma as a paradigm. Welcome, Priyanka.
Thank you, Dr. Wazinski, for that kind introduction. Here are my disclosures. And so thank you, everyone who logged in this morning to listen to me speak and the opportunity to present at Medicine Grand Rounds. As I was preparing for this talk for my esteemed colleagues in internal medicine and its specialties, I was reminded of my residency interview for internal medicine, which was a very daunting prospect as an international medical graduate coming from outside the United States health system. And at that time, I just started working as a research associate with the stem cell transplant survivorship program at the NIH. And I had merely one research abstract to show on my application looking at cardiovascular risk factors in long-term stem cell transplant survivors. I was being interviewed by a very senior primary care physician who asked me to explain my research. And I can tell you I was a nerve wreck as this was my dream program, and I wasn't sure if the words coming out of my mouth were making any sense at all. And as I fumbled through my interview, I suddenly had an aha moment. And I said, my research is essentially trying to understand primary care issues in a specialized patient population. I felt my interviewer's expression soften, and I knew I'd nailed the interview. And I still believe that that is the answer that got me into my medicine residency. And the truth is, I still believe that definition. Cancer survivorship is essentially addressing primary care issues in a specialized population who has a history of cancer. So let's talk about cancer survivorship based on my practice as a lymphoma physician. So I'll talk you through the lymphoma paradigm. Let's get to it. I hope in the next hour, together, we will learn to define cancer survivor and survivorship. We'll go over and understand the updates in lymphoma management in the last 5 years, identify the impact of lymphoma and its treatment on long-term health outcomes, and then utilize survivorship care guidelines for management of lymphoma survivors you see in your clinic. To do this, we'll start with talking about cancer survivorship broadly, then dive into some more updates in lymphoma and survivorship care for lymphoma survivors in 2024, talk about the cancer survivorship care guidelines, which would be applicable for patients you see in your clinic. And then I will close by briefly going over some ongoing cancer survivorship research efforts at the UW-Carbone Center. And this is an open invitation to collaborate, so please reach out. So when we think of cancer survivorship, it is a complex thing. It is a broad concept that focuses on the health and well-being of a person with cancer from the time of their diagnosis until the end of life. So cancer survivorship is a state of being, including the perspectives, needs, health, and the physical, psychological, social, and economic challenges experienced by people and their caregivers after a cancer diagnosis. So it's important to note that caregivers, family members, friends are also considered a part of the cancer survivorship experience and are now termed as co-survivors. Cancer survivorship care, as you can imagine, is complex because it's comprehensive care for all people who have a history of cancer. It begins at the time of diagnosis with the goal of assessing and mitigating the impact of cancer and its treatment, and includes many components of care, including surveillance and amelioration of physical, psychological, emotional effects, including late effects of the cancer, surveillance for the cancer and new cancers that these survivors are susceptible to, assessment and promotion of health behaviors like smoking cessation, physical activity, coordination of care between different care team members, health systems, survivors, and caregivers, addressing existing comorbidities and preventing and managing any chronic health conditions exacerbated by cancer and its treatment, engagement in care planning, including the discussion of goals of care and advanced care planning, provision of supportive health services, nutrition, PT, OT, rehab, fertility services, genetic risk assessment and management of social risks, health-related social needs, education, employment, and the financial hardship associated with the cancer diagnosis. I show this figure to drive home the point that a cancer survivor is any person from the time of their cancer diagnosis through the remainder of their life, irrespective of the outcome of their cancer, which means a cancer survivor could have an early stage cancer that is treated with curative intent. They could be diagnosed with an advanced or metastatic cancer that is treated with the intent to prolong their life, or they may be diagnosed with end-stage cancer with the goal to manage their quality of life. So there's no one face of a cancer survivor. This is a very simplistic portrayal of the period of survivorship. As time after cancer diagnosis and treatment goes on, the risk of relapse of their primary malignancy decreases in the first few years. However, the risk of long-term and late effects related to the disease and treatment continue to persist. And these late effects are challenging because these risks may vary over time and often occur after the transition of clinical care away from the oncology team to other members of the healthcare team. When we think about cancer survivorship for patients that we see, the factors to keep in mind are age at the time of cancer diagnosis, the type of cancer, the treatment that they receive, as well as the prognosis of their disease. A vast majority of cancer survivors in the United States are older than 65 years, as cancer is a disease of the aging. But it also means that they have more medical needs. And to note here, there are also a substantial number of cancer survivors who are adolescent and young adults, which you can see in the green and blue parts of the pie chart here. And while prostate and breast cancers predominate and are the most common cancers for male and female patients respectively, non-Hodgkin lymphomas are not far behind at number 5 and number 6 on the list. And as treatment and prognosis of cancers improve, it is estimated that there will be 26 million cancer survivors by 2040. And so we are going to encounter these patients in our practices and in our lives. We all know that surviving a cancer does not mean that full restoration of health is achieved. The American Cancer Society defines as a survivor as any person with cancer from the time of diagnosis through the remainder of their life. And this is important because in the past, we would typically think about survivorship as the period after cure of cancer. But with the current treatments and novel agents, so many of our patients live with, through, and beyond their cancer rather than living after their cancer is cured. And in keeping with this definition of cancer survivorship, I think of it as 3 phases: the treatment phase from cancer diagnosis to completion of treatment, the recovery phase from the acute toxicities of treatment, and the phase of long-term survivorship, or the new normal that survivors achieve after their cancer experience. Now let's talk about how things have changed for lymphoma survivors through the last decade, where we have seen tremendous advances in cancer diagnostics and therapeutics. This is the part where we oncologists take the lead in the patient's care, but we need so much help from our internal medicine and specialty colleagues as we navigate patient comorbidities, cancer symptoms, and treatment toxicities. So just to orient everyone, I'm a lymphoma specialist. So I see a lot of different types of lymphoma in my clinic. Broadly, we think of them as 2 major subgroups in the current nomenclature. One is Hodgkin lymphoma, which accounts for 10 to 20% of all lymphomas. And most other lymphoid neoplasms are lumped into this large and confusing group called non-Hodgkin lymphomas. In today's talk, I will walk you through the latest developments in B-cell non-Hodgkin lymphoma, both aggressive and indolent, as well as Hodgkin lymphoma, but we will not have time to cover T-cell or other rare subtypes. So in the grand scheme of cancers, non-Hodgkin lymphomas may represent only about 4% of cancers in the United States, but it is the 8th most common cancer with 80,000 estimated new cases and 20,000 deaths in 2024 alone. The three biggest slices of the pie graph you see here are diffuse large B-cell lymphoma, chronic lymphocytic leukemia or CLL/SLL, and follicular lymphoma, which is what I'm going to review with you next. So for diffuse large B-cell lymphoma, curative intent anthracycline-based chemotherapy with CHOP, which stands for cyclophosphamide, doxorubicin, vincristine, and prednisone, has been the standard of care since the 1970s. In the early 2000s, the anti-CD20 monoclonal antibody rituximab was added to CHOP and improved survival in this situation. Over the years, we've had multiple unsuccessful attempts to improve upon R-CHOP by increasing the intensity of treatment or adding new agents. But just in the last year, based on this phase 3 randomized trial comparing polatuzumab vedotin R-CHP with R-CHOP, we saw an improvement in progression-free survival, leading to the FDA approval in 2023 of polatuzumab vedotin R-CHP for the frontline treatment of diffuse large B-cell lymphoma with 2 or more poor prognostic factors. So what is polatuzumab vedotin? This is a new kind of drug called antibody drug conjugate that targets CD79B. As you can see here, it has an antibody structure, which is this Y shape in blue, and then linkers that link with it a payload of chemotherapy called MMAE, which is a microtubule disrupting agent. So when this targeted antibody is internalized in the tumor cells, it disrupts the microtubules, causing cell death. So in some ways, it is a targeted delivery of chemotherapy. The toxicity from this most commonly is peripheral neuropathy, in addition to antibody-related infusion reactions, as well as kidney liver dysfunction. This was first approved in 2019 for relapsed diffuse large B-cell lymphoma, and then in the last year, we have the ability now to use it upfront for patients with a poor prognostic score. Despite improvements in frontline treatment, 10% of patients may have primary refractory disease, meaning they have no response or inadequate response to frontline therapy. And a third of patients may respond initially, but then relapse. An early relapse within 12 months of their initial treatment is known to have poor prognosis and needs to be treated like refractory disease. We know that at relapse in diffuse large B-cell lymphoma, chemotherapy alone is not curative, and in the past, we've been using autologous stem cell transplant for these patients. What has been the most exciting development in the field of lymphoma in the last 5 years is the curative potential of this new technology called CAR T-cell therapy, because of which patients with relapse refractory diffuse large B-cell lymphoma who would have otherwise died of their disease in less than 6 months now have a 40% chance at living beyond their lymphoma. These are survival curves from the pivotal trial of Axi-cell, which was the first CAR T product approved for diffuse large B-cell lymphoma, showing a plateau at around 40% on the survival curve with very few relapses among patients who survive in the first year post-CAR T. So what is CAR T? CAR T stands for chimeric antigen receptor T-cell therapy. It is a genetically modified autologous cellular therapy where the patient's own cells are collected, genetically engineered in a lab, and given the ability to recognize a protein on the cancer cell, in the case of lymphomas, that's CD19, which allows it then to kill the cancer. Since 2017, we've had a number of CD19-directed CAR T products approved not just for relapsed refractory diffuse large B-cell lymphoma, but also for follicular lymphoma, mantle cell lymphoma, and CLL/SLL. This is a slide that I borrowed from the American Society of Stem Cell Transplant and Cellular Therapy, which I think is a simplified depiction of what a CAR T really is and how it works. Here you see a viral vector, which is inserted into a T cell, incorporating the viral DNA. This allows the T cell then to express this chimeric antigen receptor. This process happens in a lab, and then the cells are infused back into the patient. The CAR receptor enables the T cell to recognize CD19, the tumor cell antigen, which then activates the T cells, allows it to release cytokines, multiply, and lead to tumor cell apoptosis. And because of these unique mechanisms of action, we have some unique toxicities with CAR T cell therapy. Cytokine release syndrome is the severe systemic response to the activation and proliferation of CAR T cells, which presents as high fever, flu-like symptoms, changes in vital signs, organ dysfunction, and these patients need to be hospitalized, often in the ICU, and require treatment with drugs such as tocilizumab or IL-6 antibodies. Immune effector cell-associated neurotoxicity syndrome, otherwise termed as ICANS, presents as mental status changes, somnolence, stroke-like symptoms, seizures, or even coma, and is treated with steroids. There are other side effects that we see in the short term, but things such as risk of serious infections, prolonged low blood counts, hypogammaglobulinemia, and secondary cancers may be late effects that we are yet to understand fully. Just in the last year, the FDA recognized the risk of developing T-cell lymphomas in survivors treated with CAR-T. The overall risk is currently estimated to be less than 1% and doesn't necessarily change the risk-benefit ratio, but it just proves the point that we need to remain vigilant in identifying potentially late treatment-related complications with these novel treatments. So what did we do before we had CAR T-cell therapy? For patients with relapsed diffuse large B-cell lymphoma, their prognosis really depended on the chemosensitivity of their relapsed disease and whether they were candidates to undergo autologous stem cell transplant, which involves high-dose chemotherapy. Since the approval of CAR-T, first in the third-line setting in 2017, the chemo-refractory patients got a treatment option that could potentially cure their disease, even if it was not sensitive to chemotherapy. And now, since 2022, we have two CAR T-cell products, Axi-cel and Liso-cel, that are approved in the second-line treatment of diffuse large B-cell lymphoma, which means when we see patients with relapsed disease, we ask the question, were they refractory to chemotherapy, or did they have an early relapse within 12 months? And if that is the case, even if they may be ineligible for autologous stem cell transplant, they may have options of undergoing CAR T-cell therapy. And even though CAR-T provides 40% long-term remissions for relapse disease, that means 60% of patients still have relapse post-CAR-T and have a poor prognosis when that happens. So treatments to control the disease or with palliative intent are needed in the post-CAR-T relapse setting and for those ineligible or without access to a CAR-T center, since it is such a specialized procedure. And as you can see in this table, we have had many different agents that have been FDA approved for relapsed refractory diffuse large B-cell lymphoma in the last 5 years. These range in terms of antibody drug conjugates, such as polatuzumab vedotin, which I reviewed earlier, loncastuximab tesirine, which is another antibody drug conjugate targeting CD19, combination of immunomodulatory drugs like lenalidomide with CD19 antibodies, tafasitamab, and most recently, bispecific antibodies, epcoritamab and glofitamab, which bind to CD20 on the lymphoma cells and CD3 on the T cells in a way to activate and engage T cells without necessarily having to go through the logistic hassles of CAR T cell manufacturing. These drugs have been approved based on phase 2 studies, so we really don't quite know how to sequence them, and often the choice of treatment is based on the patient's goals, the administrative schedule, the unique toxicities that these bring. And with these multitude of options available, I'm actually now seeing patients in clinic who receive these treatments sequentially and live with their relapsed aggressive lymphoma for many months and years, something we could not have imagined just 5 years ago. What does this mean for our patients? These are survival trends from SEER, and this data does not include the more recent times of CAR-T and novel agent approval, which started in about 2019. So the 5-year relative survival for diffuse large B-cell lymphoma as of 2020 was 65%. And with these new treatments that we just reviewed, me and you are going to see more aggressive lymphoma survivors in our clinics. Changing gears to talk about indolent or low-grade non-Hodgkin lymphoma, which follicular lymphoma is the most common, we think of them as incurable but treatable cancers. We use this framework of symptoms and disease burden to recommend treatments. So if patients are diagnosed with an indolent lymphoma but are asymptomatic and have a low disease burden, they may be recommended just observation alone versus considering treatment with single-agent rituximab. However, if patients with indolent lymphomas have symptoms related to their disease or high disease burden, then consideration of treatment earlier with single-agent rituximab or adding chemotherapy such as bendamustine to rituximab is recommended. And even though we're still using chemoimmunotherapy in the frontline management of follicular lymphoma, there has been multiple agents approved in the last decade for relapsed follicular lymphoma, which has remarkably changed the landscape. This includes small molecules such as lenalidomide, tazemetostat, which is an EZH2 inhibitor, zanubrutinib, which is a BTK inhibitor, as well as CAR T-cell therapy and bispecific antibodies. Follicular lymphoma survival trends over time also show the same, with a declining death rate and improving 5-year survival. In 2021, there were an estimated 800,000 people living with non-Hodgkin lymphoma in the United States. Similarly, with CLL/SLL, we have moved on from using frontline chemoimmunotherapy to using targeted small molecules such as BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib, and most recently pirtobrutinib, as well as BCL2 inhibitors such as venetoclax, combined with anti-CD20 antibodies like obinutuzumab in the frontline setting. The choice of treatment really depends on patient factors, where we think about BTK inhibitors for patients who are willing to take a medication continuously long-term, versus the combination of venetoclax and obinutuzumab is a time-limited treatment over 12 months that offers good disease control. There are unique toxicities with these novel treatments that I think you need to be aware of. Because BTK inhibitor treatment is continuous, these patients may stay on these agents for a long time. These patients are generally doing well outpatient and only see me once every 3 months. So if they end up having a bleeding after car accident or need an emergent procedure, holding that BTK inhibitor and transfusing platelets, even with a normal platelet count, is important to reverse the antiplatelet effect of the agent. And so these BTK inhibitors put patients at risk of bleeding, atrial fibrillation, hypertension, atypical infections for as long as patients are on them. And so maintaining vigilance and watching for these side effects is important. BCL2 inhibitors like venetoclax usually have toxicities of tumor lysis syndrome, which are important in the first few weeks and not a long-term concern. But with anti-CD20 antibodies, hypogammaglobulinemia can affect the immune system, vaccine responses, and we saw significant poor outcomes during the COVID-19 pandemic. CLL is the most prevalent type of leukemia, affecting over 200,000 people in the United States. Introduction of these highly effective and more tolerable treatments has led to significant reduction in CLL-related mortality. And USCR data comparing patients diagnosed in 2015 showed a 5-year relative survival of more than 92% compared to those diagnosed a decade earlier. And while progressive CLL or treatment-related complications were previously the predominant cause of death, most patients diagnosed in the current era will likely die from non-CLL related causes. And so we may be coming to a point where it is likely that further improvement in outcomes for our patients with CLL will not come from improvements in CLL-directed therapy, but rather from addressing competing causes of death. Let's move on to talking about Hodgkin lymphoma, which is an aggressive lymphoma, but the first malignancy that was cured with radiation. The frontline treatment of Hodgkin lymphoma has always been a balance between curative intent treatments and then improving the survivorship experience with acute toxicity and late effect management. So our management approach has evolved over the last many decades, with the initial radiation-based cure to chemotherapy-based curative intent treatment. Once we started to cure 85 to 90% of individuals, we tried to de-escalate treatment based on interim PET-adapted strategies to minimize toxicity, and then incorporated novel agents in the frontline setting in the last few years to improve response rates and survival. These novel agents include antibody drug conjugates such as brentuximab vedotin, which is an anti-CD30 targeting monoclonal antibody with an MMAE backbone, the same backbone that polatuzumab has. And this also has the toxicity of peripheral neuropathy. It was first approved by the FDA in 2011 for relapsed refractory Hodgkin lymphoma. And since 2017, we have the ability to use this in the frontline setting in combination with chemotherapy, a regimen that we call BV-AVD. Anti-PD-1 antibodies or checkpoint inhibitors, nivolumab and pembrolizumab, have revolutionized the management of solid tumors But in heme malignancies, Hodgkin lymphoma is the only malignancy where these have made a significant impact. These work by blocking the PD-1 signaling that occurs between the T cells and the tumor cells. And by blocking this PD-1 signaling, it allows the T cells to recognize the cancer and activates mechanisms to destroy the cancer cells. I tell my patients the toxicity from these agents can be itis of any organ. So these are immune-mediated reactions, which could include dermatitis, colitis, pneumonitis, thyroiditis, essentially itis of anything you can think of. But they also can have other reactions such as infusion-related issues or fatigue. The FDA first approved this in the fourth-line setting in 2016, and more recently, these are poised to become approved in the frontline setting. And so this improvement from ABVD, which had been the standard of care for Hodgkin lymphoma since the 1970s, came with these phase 3 randomized studies looking at a combination of brentuximab vedotin with AVD versus ABVD, which showed an improvement in overall survival. And just last month, we saw this data published from a large randomized clinical trial looking at nivolumab in combination with AVD versus BV-AVD, showing an improvement in 2-year progression-free survival. And this is now poised to become the new standard of care. So Hodgkin lymphoma trends over time have also shown a significant improvement in survival and is expected to continue to get better. The important thing to note is compared to non-Hodgkin lymphomas that we reviewed earlier, Hodgkin lymphomas have a median age at diagnosis of 39, which means it affects a lot of adolescents and young adults who have very different survivorship needs and a very different survivorship experience. So now that we've reviewed some of the recent developments in lymphoma treatments, and we know that the number of lymphoma survivors is only going to increase, we need to move on and talk about long-term toxicities with newer modalities of treatment, such as the immunotherapy, cellular therapy, targeted agents that we are now using in clinic every day. And it might take years and even decades before we understand and mitigate the long-term effects of the new therapies, but we need to remain vigilant. So systemic treatment-related side effects in the immediate short term that we think about with classic chemotherapy include GI toxicity, organ toxicity, hair loss, which generally improve over weeks and months after treatment completion. But there can be other side effects of treatment like peripheral neuropathy, cognitive issues or chemobrain, changes in mood or sexual dysfunction, which may persist and stay with our patients over the long term. And then there can be late effects, such as complications that develop in the future due to the history of cancer and its treatment, and generally after the survivor has transitioned away from the oncology clinic. So let's bring all this back to where we started by thinking about survivorship as an experience from diagnosis of cancer. We reviewed that lymphomas are heterogeneous, with differing prognosis, affecting different age groups, and have varying treatments. We need to be thinking about survivorship not just for those cured with lymphoma, but also those living with and through their lymphoma diagnosis, irrespective of whether they get treatment. And indolent lymphoma patients, like I mentioned, are now less likely to die from their disease and more likely to die from other causes. And that's where we need your help. Let's think about lymphoma patients that we may encounter in our practice. Their survivorship experience can take different trajectories. The best case scenario, a patient with an aggressive lymphoma who receives 6 cycles of chemo and achieves a cure, remains lymphoma-free for the remainder of their life. Others may remain lymphoma-free but have a serious treatment-related late effect like anthracycline-induced heart failure, or have a late recurrence of their cancer, which is not unheard of. Another patient may be lymphoma-free but end up with a second malignancy, such as breast cancer in a patient who received radiation for their lymphoma. Diseases such as mantle cell lymphoma, CLL, SLL may have a relapsing remitting course. And then there are the patients with indolent lymphoma who may be diagnosed with the cancer but told that they don't need treatment and they continue to live with their lymphoma for the remainder of their life. All of these individuals are lymphoma survivors. When we think about the risk of recurrence of lymphoma, it really depends on the type of lymphoma, the characteristics of the disease, the stage at diagnosis, and whether they receive treatment or not. Surveillance is generally in the lymphoma clinic just with clinical exam and labs up to 5 years, after which they're discharged from the oncology practice. We do not routinely use PET CTs for surveillance in lymphomas, particularly aggressive lymphomas that are treated with curative intent. And we have to balance among our lymphoma survivors the fear of cancer recurrence versus scanxiety, the anxiety of going through recurrent scans. And trust me, I am not making this up. There are multiple publications describing the worry and anxiety associated with tests and scan results. When we think about aggressive lymphomas like Hodgkin's, we've had multiple studies over the years that have shown us that after the first 10, 15 years after treatment, most deaths for these survivors are not from their disease, but from other causes, such as malignancies, cardiovascular disease, and pulmonary disease. So clearly, we oncologists are no longer the ones saving lives for these patients. Secondary malignancy is defined as a new cancer that is biologically distinct from the original cancer. And cancer survivors across the board have a higher risk of having a second malignancy compared to the general population. Here I show data from the SEER, where you see Hodgkin lymphoma listed on top as the #1 cancer with the risk of second malignancy. The risk does vary by primary cancer type, treatment, age, and health behaviors, and is especially important for AYA survivors, Hodgkin lymphoma survivors, and patients of tobacco-associated cancers, which tend to cluster together. And Hodgkin lymphoma and non-Hodgkin lymphoma, being diseases of the immune system, are more susceptible to secondary malignancies. This is data from a large study of close to 4,000 5-year survivors of Hodgkin lymphoma in the Netherlands, aged 15 to 50. And what I want you to note here is the graph on the left shows in the red line survivors who are treated in the most recent era studied, 1989 to 2000, versus the gray and black lines looking at prior eras. And despite improvements in treatment, it doesn't seem like the risk of secondary malignancies has decreased over time. The graph here on the right on top shows the standardized incidence ratio, which is the comparison of the incidence of second cancer observed in the study cohort compared with the expected incidence in the general population. And what you can see is that standardized incidence ratio remains high even as we move more than 30 years past the cancer diagnosis and treatment. These secondary cancers may arise due to a history of radiation. The classic example is breast cancer in childhood Hodgkin lymphoma survivors treated with radiation. And that risk is estimated to be about 20% at age 45, which is extremely high. Thyroid cancer for radiation to the neck, lung cancer if lung fields are included in radiation, and this risk is compounded by a history of smoking. Gastric, colorectal cancers, sarcomas, and skin cancers can also occur within the radiation field. And then due to chemotherapy, we are mostly dealing with hematologic malignancies, such as myeloid neoplasms due to alkylating chemotherapy. And being immune cancers, non-Hodgkin lymphomas are increased in patients who have a history of Hodgkin lymphoma. So what does this mean in terms of cancer screening? It is advised that lymphoma survivors are made aware of their increased risk of developing a secondary malignancies, undergo age-appropriate cancer surveillance, and report any concerning symptoms. And smoking cessation might be the single most important change they can make in their lifestyle to decrease their risk of developing a secondary cancer. For breast cancer screening, the guidelines state that starting at age 40, patients should undergo an annual screening mammogram, or if patients have a history of chest irradiation, then they should start screening for breast cancer 8 years after radiation is completed, or age 25, whichever is later. For patients who receive radiation to the chest between the ages of 10 and 35, which is when the breast tissue develops, we should consider annual breast MRI imaging in addition to the mammogram. And there is consideration for referral to the high-risk breast clinic for discussion of chemo prevention strategies. For lung cancer, especially for those with a significant history of smoking, annual low-dose CT scanning starting at 5 years after initial cancer diagnosis is recommended. Skin cancer prevention by sun safety practices and surveillance through annual complete skin examination is recommended. For colon cancer, Hodgkin survivors have an increased risk of colon cancer, and they should begin screening 10 years earlier than the general population. And anyone who has a history of radiation to the abdomen should receive a colonoscopy starting at age 30 or 5 years after the radiation is completed. Prostate cancer risk does not seem to be higher in lymphoma survivors, but cervical cancer risk may be increased for patients who undergo allogeneic stem cell transplant and are dealing with a chronic inflammatory condition called GVHD, where they may need increased frequency of pap smears. Moving on to cardiovascular disease, this tends to occur late, 10 to 20 years after initial treatment, and is compounded by the patient's cardiovascular risk factors that may be pre-existing or develop after cancer treatment, such as smoking, lack of exercise, family history, high blood pressure, high cholesterol, diabetes, and then premature menopause due to cancer treatment also adds to the risk. Radiation causes scarring of the pericardium, myocardium, conduction system, arteries, and valves if the heart is included within the radiation field, and chemotherapy such as anthracycline leads to myocyte loss and damage. This is from a study of childhood cancer survivors who had Hodgkin lymphoma and were an average 16 years since their initial diagnosis and treatment. What this study shows is in blue, the patients who did not meet the recommended exercise criteria of 9 met hours per week back then had an increased risk of any major cardiovascular event. And this was estimated at 10 years to be 12% versus only 5% for those who reported meeting the exercise guidelines. And this study is a case in point that adherence to the recommended exercise guidelines is associated with a significant reduction in cardiovascular events, even in cancer survivors. So what does this mean for patients you see in clinic? It is important to advise lymphoma survivors of their increased cardiovascular risk and at minimum instruct not to ignore any persisting troubling symptoms and report promptly those symptoms to their physicians. For cardiac disease, referral to a cardiologist for baseline evaluation after treatment with anthracycline or radiation is recommended, and we have a cardio-oncology clinic here at UW, which we often use for our patients who may have abnormal baseline findings on their pre-treatment echocardiogram, especially for patients who receive more than 30 gray of radiation to the mediastinum or more than 240 milligram per meter square of doxorubicin, which is standard as a part of aggressive lymphoma management. It is recommended that you consider screening them with a stress echocardiogram 5 to 10 years post-treatment and then every 5 years. An annual examination for carotid bruits and ultrasound of suspicious clinical findings is recommended. And most importantly, modifiable risk factors need to be emphasized, such as regular physical activity, nutrition, and diet as per the primary prevention guidelines. And optimal management of cardiac risk factors is very important in this patient population, even more so given the history and risk of cardiovascular disease. I want to make a point about patients on BTK inhibitors again. So these are the oral agents that are used to treat CLL, SLL predominantly, but are also being used in other lymphomas. They have a risk of developing hypertension as well as atrial fibrillation. And we often monitor their blood pressure in the early visits when we start them on these medications. But it is recommended that they undergo an echocardiogram if they have a high cardiac risk and anyone who develops atrial fibrillation. Moving on to thyroid disease, radiation to the neck leads to hypothyroidism in 50% of cases and also can lead to the development of thyroid nodules over the long term. Thankfully, majority of those have been shown to be benign. Steroids, early menopause increase the risk of osteoporosis and osteopenia in cancer survivors. And pulmonary fibrosis, lung disease, pneumonitis can occur because of the treatments that our patients receive, and this risk is compounded by smoking. Fertility is a very important issue for our younger patients, and fertility preservation is something we have to think about for every patient who is of reproductive potential before they get their cancer treatment. But once they have completed cancer treatment, and if they are trying to conceive, it is recommended that they wait 2 to 5 years post-treatment to have children. Studies have shown no increase in birth defects, miscarriage, or cancer in the offsprings of cancer survivors compared to the general population. And it is also important to screen for sexual health concerns in cancer survivors. So in your clinic, counseling patients to report any symptoms that suggest endocrine dysfunction is important. Referring to a reproductive endocrinologist for patients who are trying to conceive and have concerns about infertility related to their cancer diagnosis is important. Patients who have received radiation to their neck or mediastinum should be screened with a thyroid exam and annual TSH. Diabetes screening every 2 years, especially if they've been radiated in the area of the pancreas. For bone health, which is something which we don't address enough, optimization of vitamin D and calcium status and weight-bearing exercise is important, and DEXA screening for cancer survivors who have a history of steroid exposure in addition to other factors is important. For pulmonary disease, the guidelines are not very strong. They advise reporting symptoms and assessing pulmonary findings on regular examination and counseling to avoid smoking. Pulmonary function tests are performed when we give patients drugs such as bleomycin, which have an increased risk of lung toxicity, but we have moved away from using these drugs over time. Moving on to recurrent infections. We know that lymphoma patients are at increased risk of developing infections, and then they are treated with therapies such as immunotherapy, stem cell transplant, CAR T cell therapy, which can add to this risk due to the prolonged cytopenias and immunodeficiency that predisposes survivors to infection. These figures are from studies of COVID vaccine effectiveness. On the right, you have CLL patients in the colored graph and healthy subjects in the red, and you can see a significant difference in responsiveness to COVID vaccines in CLL patients who may not even be on active treatment. The graph here on the left shows the response rates to the COVID vaccine in solid tumor patients without active chemotherapy or with active chemotherapy compared to hematologic malignancy patients with and without active treatment, and heme malignancy patients are predisposed to lower vaccine effectiveness. But despite this, my motto is to do something rather than nothing. And so vaccination is recommended for my patients with lymphoma, preferably before they start treatment. If it is season for flu or COVID, they should get vaccinations even if they are on active treatment. And they should get all their age-appropriate vaccinations, including pneumococcal vaccine, and the shingles vaccine is particularly important. Most of my patients are on acyclovir to prevent reactivation of zoster, but they need to be vaccinated for shingles before they're able to stop their acyclovir. The important message also is to avoid live vaccines, but thankfully with improvement in technology, the only live vaccine we currently have to think about routinely is MMR. For patients who have recurrent infections and a history of lymphoma, especially if their infections are requiring hospitalizations or antibiotics, thinking about hypogammaglobulinemia and considering IVIG replacement is an important consideration. For patients who undergo stem cell transplant or cellular therapy, such as CAR T, we actually recommend repeating vaccination with childhood immunizations, and you may see a whole vaccination schedule sent to your office if these patients decide to get their vaccinations through their primary care clinic. Talking about chemo brain or cognitive dysfunction in cancer survivors is particularly challenging because this is something that is hard to quantify except with neurocognitive testing and can present as deficits in attention, memory, executive functioning, information processing speed. Studies in stem cell transplant survivors more than 5 years out from their treatment have shown that chemo brain does improve, but may not completely resolve with time. And so it is important to at least acknowledge and consider this in our cancer survivors. Anxiety in lymphoma survivors has been shown to be higher than the general population, as is post-traumatic stress disorder, which has been noted to be significantly higher in lymphoma patients compared to the general population. So it is important to think about the neurologic and psychiatric effects of cancer and its treatment on our cancer survivors. And all patients at higher risk, such as those who've received cranially directed radiation, intrathecal chemotherapy, should undergo screening for neurocognitive impairment if they have any concerns of symptoms. Cancer-related fatigue is another challenge. This is defined as a distressing, persistent, subjective sense of physical, emotional, cognitive tiredness or exhaustion related to cancer or its treatment that is not proportional to recent activity and interferes with usual functioning. It differs from fatigue in everyday life, which is relieved by rest and is temporary. A quarter of survivors of Hodgkin lymphoma can have significant fatigue many years out, and this fatigue has been associated with higher symptoms of anxiety, PTSD, and lower quality of life. I describe to my patients that fatigue is going to get worse with each cycle of chemotherapy because they never recover completely between each treatment. And the recovery in the post-treatment phase is generally very slow. And a third of patients may have persistent fatigue for many months or even years after completing cancer-directed treatment. The causes of cancer-related fatigue are complex and can include medical issues as well as metabolic, nutritional, hormonal changes, deconditioning, or changes in mood and sleep disturbance. Management of cancer-related fatigue is challenging, and the most evidence counterintuitively is for physical activity interventions or psychosocial interventions compared to medications. There isn't any pill for cancer-related fatigue. There's lots of evidence to support exercise, even in cancer survivors, and it's known to improve fatigue, mood, sleep, physical function, quality of life, bone health, risk of heart disease, and also has been shown to decrease the risk of cancer progression and recurrence, which is often the most motivating factor when we speak to cancer survivors. The recommended physical activity is moderate intensity aerobic activity for at least 3 times per week for at least 30 minutes with or without resistance training. And this website that I have down here, exercisesmedicine.org, I find very useful to refer patients through, and they have a separate section on moving through cancer. The main motto is start where you are, use what you have, and do what you can. Sit less and move more is an easy thing even we can apply to our lives. Talking about nutrition and healthy body weight, we know that overall prevalence of obesity is higher in cancer survivors than in the general population, and this may increase the risk of side effects such as fatigue. A plant-forward diet has increasing data that it reduces the risk of subsequent cancers as well as chronic disease. And so as we reviewed, cancer survivorship really spans the entirety of an individual's life, and they have a lot of different healthcare needs that are included within survivorship. Increasing awareness and understanding among survivors, their caregivers, primary care providers, and non-oncology specialists is important to meet these needs. So with that in mind, let's think about cancer survivorship research, which is also complex as it looks at many aspects, layers, and has multiple stakeholders. Cancer survivorship research seeks to understand the health and well-being of all cancer survivors as well as their co-survivors, with research aiming to prevent and mitigate the acute and late occurring physical, psychological, social, economic effects of cancer and its treatment, improve care delivery, promote healthy behaviors, develop and sustain a research infrastructure, improve cancer research methodologies for individuals impacted by cancer. And I would like to highlight some of our recent projects through the UW Carbone Survivorship Research Program. The first project was a quality improvement study in allogeneic stem cell transplant survivors, who are an extremely subspecialized group of cancer survivors with complex care needs. And we decided that survivorship care plans have enough data to support their use and lower distress and improve quality of life in cancer survivors, specifically allogeneic stem cell transplant survivors. A lot of pilot work went into this, including surveys of patients as well as primary care providers, which led to the development of content. And as you can see, the treatment summary took a backseat compared to more important issues that were identified, such as contact information and general follow-up recommendations. This is the first nurse navigator-led survivorship care plan creation and delivery telehealth program for allogeneic stem cell transplant survivors here at UW. Overall, when we surveyed these patients who received care plans, they found the care plan transition visit and the document itself helpful. And to me, this was the most interesting finding, which is when asked to rank in order of importance, all patients who were surveyed ranked who to contact for specific needs I may have as the number one important part of the survivorship care plan document. And that speaks to the fact that patients with more complex needs need more education about who owns which aspect of their healthcare. We're hoping to expand the survivorship care plan delivery for autologous stem cell transplant and CAR T survivors. The next was a project done this year, an online survey sent to all UW Carbone Cancer Center clinics, including medical oncology, radiation, as well as surgical oncology. And we found that we have dedicated survivorship clinics for breast cancer, pediatric oncology, and adolescent young adult cancers, and hereditary cancers. But for those respondents who did not have a dedicated survivorship clinic, the biggest barriers were really time, both for patients and providers, and lack of support systems to develop survivorship care. This is a complicated slide, but essentially it are the results of the question that was asked on the survey: which of the following issues does your clinic routinely address as a part of patient care? The first column is the answers from the responders who have a dedicated survivorship clinic, and the second column is those that do not have a dedicated survivorship clinic. And as you can see, they all do really well in terms of assessing the risk of disease recurrence and survival's functional capacity, treatment-related side effects. But the differences are really in terms of preventative care, where we talk about exercise, weight management, fertility preservation, sexual health, survivorship experiences, access to peer support, and risk management. And the comment down below really summarizes it. All of the above are addressed periodically, but not routinely, as there's not enough time for a clinic visit to cover this in detail. So really, the main difference between having a dedicated survivorship clinic versus not is screening for these survivorship care needs and addressing them rather than addressing them on an as-needed basis, which I think we all are trying to do as oncologists and physicians for our patients. Those who do have survivorship clinics require a lot of multidisciplinary collaboration and involvement of multiple specialties. And so this isn't something that oncologists can do single-handedly. And I'm fortunate to work with Dr. Lee Miller from Pediatrics, who works with the Pediatric and AYA Survivorship Clinic, and we're mentoring Shapiro students to do the next steps, which are qualitative interviews to identify success and barriers to survivorship care at UW. And the vision for cancer survivorship care at UW revolves around developing supportive care services for patients on active treatment who are at the end of life, as well as long-term survivors. And this effort is being led on the UW Health side by my colleague, Dr. Dittis, who is an integrative oncologist, while we work on the research aspect of survivorship care. And so the takeaway points, hopefully, from this talk were that a cancer survivor is now defined as a person from the time of cancer diagnosis through the balance of their life, and not just patients treated with curative intent. Lymphomas are complex, heterogeneous in terms of clinical course management and prognosis. And as more lymphoma patients are living longer with and beyond their diagnosis, survivorship care for these patients is very relevant. Long-term toxicities and late effects with newer therapies in the last decade remain to be understood. And cancer survivorship care requires a lot of coordination and collaboration across oncology, primary care, and other specialties. And preventative care is the most important piece. And with that, I will open up to questions and also invite you to come collaborate with the survivorship research program at UW Carbone. Thank you.
Thank you. That was excellent. Great overview of all the advances that have happened in terms of lymphoma treatment, and then really thinking about that impact of long-term for our patients as we've improved survival and outcomes. Several questions came up in the Q&A, so I'll just kind of go through some of those. I think this is a really important one. It was from Dr. Ferguson in rheumatology. So do patients have difficulty getting coverage for cancer screening during survivorship? Is there kind of outside the protocols of the general population?
That's a great question. And I honestly do not know the answer to that, because I am not generally the one ordering the cancer screening for these patients, and that's usually driven by their primary care physician. But I think most of the guidelines are same for the general population, except some nuances, in which case I think you may have to appeal to the insurance and explain the rationale for why you are increasing screening or using a different modality, such as a breast MRI. But I know, like, we have a high-risk breast cancer clinic here at UW, and I'm sure the patients who go there are able to get the appropriate cancer screening. But I personally do not have experience with that.
Maybe I'll add, since I led the high-risk clinic for several years. Yeah, for the most part, it was well covered, but that's breast cancer screening too, amplified with MRI screening as well. But I think as long as there was justification and you can order kind of with a specific code, that's says high risk for breast cancer. That helped. But I think this is also a really great one, and kind of what was some of the end of the talk when you were talking about our current structure here and how we see these patients and meet these patients' needs. But it's really about after lymphoma is cured, or I'm going to put this as a kind of the bucket of all of our cancers. Do you continue following patients to help with future cancer screening? And if not, how do we envision how oncologists, hematologists transition patients back to the PCP, but also ensure that that information is shared?
That's a great question. And I think that is really the challenge of survivorship care. It's that transition piece when patients go from the oncologist back to their primary care or other specialists. And we don't really have a good mechanism. And I think we need to build that. Survivorship care plans were thought to be like the holy grail, and they were like mandated at some point by the COC. And then we learned that just having a document doesn't mean that we have improved communication. So I think we're open to exploring ideas of how that may be possible here at UW. And I think the bigger challenge system-wide is that every system is so unique that there can't be like one solution that is applicable to cancer survivors all across the country, because every place that even I've had the opportunity to work at has different ways of communicating and different collaborations. Some patients are going to be seeing primary care providers within UW. Others may see providers who are not at UW. And so I think it's very hard to come up with a universal solution. And so right now, I feel like the onus really lies on the patient. And the best we can do as oncologists are educate the patient about this is what you need to do and talk to your primary care provider. And then within UW, we share our notes and we're able to at least have that piece of communication. But I think it's extremely challenging for patients who come from outside UW, and we don't have an easy way to reach their primary care physicians.
And I think I'm going to add to that and combine with Dr. Gale's question, but also one that I had related to this. So, I mean, we can do things that are fixed in time, right? If we write our note with recommendations for the future, we talk to the patient, that's fixed in time with the recommendations that moment. But I learned from your talk today about earlier colorectal cancer screening. I would not have known that. I think that's a newer guideline, maybe not. But like, how do we do this in the era where like data emerges and things change and our cancer screening changes? We now have Cologuard, things like that. So how do we maybe make this a living document that like sits somehow with informatics support in EMR, that it changes as recommendations change?
Yeah, so hard. I know there are efforts going on like from app developers, and like I work with the Lymphoma Research Foundation, and they actually have like a patient-facing app. So it's not necessarily healthcare communication, but a patient able to enter their history, and then that may be something that gives more updated recommendations. And then once patients, move out of oncology care, like it's very hard. Sometimes they don't stay up to date, don't want to stay up to date about what changes have occurred or what new findings have come about in terms of long-term and late effects. So yeah, I agree. That is very challenging. That needs to be a dynamic document of some sort or dynamic process to keep patients updated.
And when we rely on the patients, then we maybe are, making health disparities even worse because there's this health literacy and engagement that is a disparity, right? So okay, and I think similarly themed, Dr. Garofalo asked, how do we even know kind of where the patient like got radiation, right? Like it will say the diagnosis on the problem list, but it won't say if it was chest radiation or pelvic radiation. So is there ways to put that in the problem list or make that clearer?
I mean, the radiation oncology note always has the details, but you'd have to go looking for it. It's not usually on the problem list. I agree with that. I mean, I think the simplest way really is to talk to your patient, and they're usually able to tell you where they got their radiation. It's not a great thing to rely on them and their memory, but I think that is really the easiest way to figure out what radiation and where they received it. They may not know the dosage, but they will know where they got it.
Great. Well, I think we're just about out of time. I want to also thank you for the wonderful grand rounds. And, my take home message is that there's lots of opportunities in cancer survivorship. which is wonderful because it also means that the population of our cancer survivors is expanding. And as we've been more successful in treating, it's really focused on those long-term outcomes and how do we improve those. And I think it's clear from many of the questions that there remains a gap between care and oncology and transitions to primary care, making sure those patients get the care that they need. And that's going to be even more important because our oncology doesn't have the capacity to continue to follow the long-term survivors as they are becoming increasing prevalent, which is awesome. So Priya, I think your work is even more important now. So looking forward to our next grand rounds that you're going to give, and tell us how you've solved some of these challenges as we move forward. So thank you again, and thank you all for your attention.
Everybody have a great day.